thank you to the conference organizers. A fantastic lineup. So you're going to get the MD perspective of things in this talk, and students, we estimate there are 10 medical schools in the country that have an elective for medical students to learn about nutrition and application and obesity medicine, and I have one of them. If a student or resident is on our rotation, they rotate through what most academic centers believe is the way to treat obesity and diabetes, and that's the surgical program. Most centers have that. They also rotate through my clinic, which is low carbohydrate. They rotate through the Rice House program, which is high carbohydrate, low calorie, put Durham, North Carolina on the map as an obesity treatment center about 100 years ago. They rotate through several other programs, and we all have different ways of going about it. I got into this area out of serendipity, listening to what a couple of my patients were doing as I was an ambulatory care doctor at a VA hospital. Followed the clinical signal, and what I'm going to do today is summarize from clinical medicine history, from science that's new, from doctors that have used this for their careers. I pass along a lot of that knowledge as well. And what I've come to as the brief resident teaching moment in the elevator, or if they come to my clinic for a half day. Protein comes first. It's not negotiable. You have to have protein. Second, you can run your body on carbohydrates or fat. It's your choice, and you can manipulate that choice by feeding your body what you want to run on. This is controversial to say that we don't know which is best and all that, but if you're trying to lose fat weight on your body, it was found out 150 years ago that if you just didn't eat carbohydrate, your body had to start using its own fat. That's called the Banting diet. You saw the history of it. So you can choose, your body burns what you feed it. You can choose to become a fat burner by not eating carbohydrate and by eating fat. As you just saw in Jeff's talk, you handle the food differently. And most people come to me for the treatment of obesity and diabetes today at Duke University. But what I'd like to do is go back in time. 100 years ago, Elliott, Proctor, Joslin recommended a low carbohydrate, high fat diet as shown in a diabetic patient, Mary. Dietetic treatment is of the first importance, and I wish I had been taught that in medical school from day one. I want to start that new medical school that has that on the first day. I'll help you. You want to create one, I'll be there. The carbohydrates taken in the food are of no use to the body in diabetes and must be removed by the kidneys, thereby entailing polydipsia, polyuria, pruritus, and renal disease. That's the loss of glucose in the urine. They couldn't measure the blood then. Mary H. was put on a stringent diet consisting only of protein and fat. The beneficial effects were seen at once. She gained 5 or 6 pounds and was advised to eat all the cream, butter, and fatty food possible. You know what the glycemic index of fat is? 0. The PhDs talk about the glycemic index and all this and the grams and the absorption. We're going to go down so low, we're going to talk about grams of carbs. Back to what they did 100 years ago, how about 0? How about 10 grams? How about 20? Well, they found out empirically through trial, Frederick Allen, sorry, it wasn't just Joslin. Have you heard of the Joslin Clinic in Boston? Yeah, they have no clue. Totally forgotten. I found this, though, on the timeline in the lobby about Elliott P. Joslin putting his mother on a low-carb diet. Interesting. So Frederick Allen basically said the same thing. But what they did is they starved people. So the single most potent intervention for out-of-control diabetes is not eating, otherwise known as starvation, otherwise known as fasting, otherwise known as not eating. It's okay. It's okay. In fact, it's therapeutic. So what they did is they put people in the hospital, took away all the food till the glycosuria, so they only could measure sugar in the urine, which is kind of a high blood sugar when you have sugar in the urine. So they were not getting perfect control with what they were doing, just as an aside. But so first the patient was fasted until the glycosuria was no longer present. Then carbohydrates in the form of green vegetables were introduced, starting at 10 grams per day, and increased until the glycosuria threshold was reached. This is probably 160 or 180 milligrams per deciliter in the blood. So they were not getting great control, but they were measuring the urine. So glycosuria threshold, they reintroduced protein until the glycosuria threshold. So protein raises sugar, puts it in the urine, combined with those carbs. We hear about that all the time. You need to moderate the protein because some protein can be turned into glucose. This level was maintained, and then protein was added to the diet, about 1 to 1.5 grams per day, which is oddly enough the current recommendation as you're treating someone who's obese. Data from Don Lehman and Jeff Volek very recently. Finally, fat was added to the diet to provide calories for weight gain. Fat was observed to have little effect on the glycosuria. It doesn't affect the blood sugar, it doesn't affect the urine sugar. For some patients, a weekly fast day was recommended. When I was doing my first study, which was almost stopped by the hospital director who was lobbied by the dietitian, well-intentioned, thought I was going to kill people by having them eat fat. Jeff, looking at a blood cholesterol of 350, no one's going to die from that, okay? But we have this fear of, immediately. No one's going to, it's not dangerous, like I'm going to fall off a cliff. And yet doctors will talk to you as if it's urgent. That's not true. So anyway, I get this book, which was, almost like manna or a divine intervention, manna from heaven, something like that. So 1923, the Osler textbook of medicine, 10 grams of carbohydrate in the diet per day, not per meal, per day. And this, I just blew it up so you could see it here. It's the same recommendation, 10 grams of 40 calories of carbohydrate per day, 75 grams of protein, 150 grams of fat. And what most of my patients focus on is they also gave alcohol. The strict diet was meat, poultry, game, fish, clear soups, gelatin, eggs, butter, olive oil, coffee, and tea. References there at the bottom. Let's see. Oh, I wanted to point out that the vegetable list that I'll show you that I use in my clinic today is very similar to the low glycemic, low carbohydrate containing vegetables on this same list from 1923. The effect in the human body has not changed all that much over this last 100 years, if you were wondering about it. So the history of diabetes tells us lots of important things today in the context of carbs in the diet and in the use of and understanding of insulin. This child here had no insulin, and then insulin is given, and he's able to store fat on the body. So insulin is required to store fat. In fact, it's a very potent signal to store fat on the body. Similarly, this girl had no insulin, was given insulin, saved lives, dramatically saved lives. In fact, before this discovery of insulin, type 1 diabetes, an individual with type 1 would become emaciated. Despite the high energy intake, fat storage couldn't occur. This was called starvation in the midst of plenty, because the body would be thin despite large energy intake. So insulin therapy for insulin deficiency allowed individuals with type 1 diabetes to live. A miracle. However, the story in type 2 diabetes and obesity is that when people imagine the surprise when someone with a high blood sugar was found to have a high insulin level. How could that be? Because if they had insulin, that would keep the blood sugar down. So the idea of insulin resistance came about. So they're able to store fat, but unable to use the fat because insulin locks it up in the fat cells. They have excessive fat store in their body, and they're starving or feel hungry because their glucose swings and constant fat storing. And the remedy for type 2 diabetes is to reduce insulin. Not to give it, to reduce it. This makes sense and has been missed by a whole field of medicine worldwide. The pathogenesis says reduce insulin in type 2, not give it. So that introduces the difficulty that we have today. Long story, it's a whole nother lecture, how the organization started pushing carbs. I think the short answer is this. If a doctor puts someone on insulin or some medication first that causes low blood sugars, dietitian educators, diabetes educators are saving lives by telling people to eat carbohydrates because the medicines are causing terrible hypoglycemia. And now you get this situation where the individual is blamed for being hungry and eating and gluttonous when it's a physiologic response, and they're now trapped in having carbohydrates in the foods because they're not off the medications. It's just tragic. But now imagine that you were in charge of the insulin and the medicine and the diet. Hey, that's what we can do. We're going to take charge of both, okay? Sadly, even at Duke, I have a push-pull at endocrinology, put them on more carbs and on more insulin. Come to me, I take them off the carbs and off the insulin, back and forth, and the patient is caught in the middle. A lot of education that we do, and most decide to come toward me because they don't want to be on the insulin. It's just another way to go about it. There's another way to say it. Now, you saw some slides yesterday of what happens when you eat carbohydrate and the glycemic index. Well, what happens when you don't eat carbohydrate? There's no postprandial rise in glucose. And all the research about all of the bad things about postprandial hyperglycemia and all this stuff, just don't eat the carbohydrate. The best study, if you want to look at the inpatient, so you know exactly what people are eating kind of study, Gunther Boden, Annals of Internal Medicine, 2005, their ad-lib diet, and then the low-carb ad-lib ketogenic diet. Glucose levels and insulin levels are almost flat after eating meals and good nutrition. All the foods that you saw Jeff show. Okay, so not just the Boden, this is a reliable response around the world. You have no carbohydrate in the food. There's no postprandial rise in glucose compared to the other meals with carbohydrates. And it's been said, and it's true, that protein raises the insulin, but it's much lower rise in insulin. Insulin actually helps amino acids get into the cells. This is basic physiology 101, and I think that probably insulin's real role is to facilitate amino acid absorption and then facilitation of carbohydrate storage as fat whenever you had it around. But to have it control blood sugar every day, all the time, I think insulin is being used for something else. Just what I see from my desk. Another paper out of Australia, Manny Noakes, the glucose tolerance test is, why would you ever give someone 75 grams of sugar? Why would you ever do that? Especially someone who's not eating sugar. Don't do those tests, okay? This is called a diet tolerance test where they got a low carbohydrate diet, and again, the glucose doesn't rise, the insulin doesn't rise there in red. This is not rocket science. This is basic physiology. So when I was looking around for applications and treating now as an internist, now as an obesity medicine specialist, I looked at doctors around the country. I looked at Dr. Atkins, I looked at Dr. Bernstein, went to their offices and reviewed their charts. And at the time, the mainstream research organizations premier in the world were getting A1Cs 7 or so, 7%. But the diets all had lots of carbohydrate in them. Seeing these doctors in practice achieving A1Cs that were normal was remarkable. And I kind of said to myself, I want to be able to do that. And if it's safe, and if it is, this might even be something to consider to do in my own practice. So I went out, this is the empiric use, watching doctors already in practice and then borrowing that and doing research on it. One of the questions was, how low on the carbohydrates can you go in the diet? And actually, the Institute of Medicine, DRIs, which is probably the most unbiased source of information you can find. a lot of biased information in other organizations. The lower limit of dietary carbohydrate is 0. You know, when I was first faced with, you have to have carbohydrates 120 grams per day, and I said, well, what about people who get hospitalized and they don't eat? Have you ever been so sick you didn't eat for a day? Oh, right. I mean, I smelled a rat. Didn't you? I mean, when people say you have to have this, you have to have that, and your own life experience says, well, gosh, that's probably not true. Those are great areas to go into and research and finally, when I did the studies, one of my colleagues back home said, you know, you were like shooting fish in a bucket. You went and visited doctors, saw what they did and that it worked, and then came back and did studies. That's not fair. And I said, well, I got money for it, you know. But nobody believed it. So I visited Dr. Atkins, and actually Jackie Eberstein is here, who worked with Dr. Atkins for a long time, and realized that there was such a lack of confidence, lack of faith in those practitioners, that data from those places wouldn't be believed, wouldn't be trusted. So what's a good researcher to do? Ask for money, go back home and do the studies. So we did several studies on obesity and looking at the lipids, found what Jeff basically said, and then we went into diabetes. Our study was published in 2008, and it stands out from the other low-carb diets because we did that 20 grams of carbs per day, which was done 100 years ago by the, yeah, okay. But through the lens of the carb-pushing mainstream, it seems really low to go to 20 grams. When I'm here saying you don't need any, 20 looks kind of high. You know, it's all your point of view. So a lot of studies now lowering the carbs. After 8 years of clinical research and then visiting doctors and looking at their data, you know, really looking them in the eye, making sure they weren't lying to me, and making sure they weren't sued through the years, you know, I figured I'm going to open my own clinic, set up a model clinic, and over the last 8 years I've done that at Duke. My default treatment is less than 20 grams of carbohydrate per day, and I use a method that was used for a long time, like you saw 100 years ago. A teaching tool that I use, not only the protein is first, you can run on fat or sugar, it's your choice, and then forget about what everyone else has taught you about diet. I forgot to tell you my third rule. And that is because just yesterday you saw David Ludwig present research that the starvation response that I hear about all my patients, about the starvation response, I need to eat, it didn't happen on the low-carb diet. He presented that data yesterday, and it's a study that he did in his shop just recently. But anyway, another teaching tool I use is how much sugar is there in the blood? If you could pour it out and measure it, and I pimp my students and residents, and I say, well, you should know. I don't give them a hard time. I'm a pussycat. But it's in front of you every day. So 100 milligrams per deciliter is the measure. Some of my students don't even remember the units, right? Oh gosh. But it's 100 milligrams per deciliter, 10 deciliters per liter, 1,000 milligrams in a gram. And then I'll give that, okay, there are 5 liters of blood. Basically, there's 5 grams of glucose in the entire bloodstream at a given moment. Why would you be putting more than 5 grams of sugar or carbs, which starches get digested? Why would you be putting more than that in a system that only has 5 grams in it to begin with? If you could have another source of energy that didn't, the body doesn't like the blood sugar to go up. If it's up all the time, that's called diabetes, with the attendant consequences of diabetes. So the system has very little carbohydrate. Oh, I didn't remember, now this is middle school mathematics. You cross out this, cross out that, and so you're left with 5 grams. I have this on the wall in my clinic, and you know, when I keep people waiting, they look at things on the wall, and it's a pretty powerful teaching tool. So that if you have a teaspoon and a half of sugar going around in your bloodstream, you have diabetes. Well, oh, why would I want to eat a Snickers bar or have a sweet tea in North Carolina? It's a great teaching tool. In my mind, there are good carbs and bad carbs if you want to do that. The good carbs are these guys, the bad carbs are these guys. Pretty much everyone agrees with that. today. If you're looking at measurement of all these things, again, I guess I'm just the MD guy using the empirical approach. I was taught grams of carbohydrates, not glycemic index. In fact, these are so low on the glycemic index, they're off the scale. Because a very small amount of carbohydrate, regardless of it being low glycemic, will raise the blood sugar. So this may be different. In fact, Jeff pitched the slide of percent carbs of the diet calorie. No, we use total. Works pretty well. So if you're under 50, some people are in ketosis. Now we define this by ketonemia, and yet what is the best ketone level? Nobody knows. It's all that, we're seeing the research here. It's awesome to see it being done. If you get under 20 grams of carbs today, empirically, just about everyone will have ketones in the urine, an increase in the blood, but not everyone. Not everyone will have that. So, but this is the grams of carbs. I use 20 grams or less, and these are the popular fruitions of these, and there'll be many more, I'm sure, which is good. Let's see, Dr. Ludwig's would probably fall somewhere in here, I think. So what do you eat on a less than 20 grams of carbs diet per day? It's actually pretty cool, and this there may be some local variation. We helped do a study north of Vancouver in a native Canadian or First Nation study in rabbit moose, and venison is not something you'd find in North Carolina. So, and then the fiddleheads. But so you may have to tailor the food that you eat based on your local variation of, and vegetarian, non-vegetarian. It's all doable. But basically you can have as much as you want of the meat, poultry, seafood, and eggs. Don't limit those at all. But you eat until you're comfortably full. Hara Hachibu is 80% full. It's how people in Japan are taught from childhood to eat until they feel full, rather than the way I was taught to eat everything on my plate because they're starving children in Japan or China or Africa. And in fact, I wouldn't get dessert unless I had everything on my plate. So that's how you make an addict. Force me to go through something I don't want to do so I can have the sugar, So like most Americans, not Swedish folks, they don't seem to have this problem. If you're raised on sugar, you're likely to become a sugar addict. But so until you're comfortably full, 2 cups of salad greens, 1 cup of a non-starchy veggie, and I say, I don't even want you to measure things. Take your fist, compare it to a measuring cup, and it's just about a fistful. And sir, if your fist is a little bigger, you can probably have a little more lettuce, So what we're dealing with in terms of measurements are things that are extremely low in carbohydrate. And 1 fistful of a non-starchy veggie for the whole day. And yeah, it's a common mistake to overeat those because on a low-fat diet, people were taught to eat as many vegetables as they want because there's no fat in them. On a low-carb diet, we say things like you can have as many eggs as you want because there's no carbs in them. It's just a different way to do it. I'll say that you've learned how to drive in the right-hand side of the road, but that's not the only way to do it. If you go to England or any other country that was owned by England, or heavily influenced by England, they drive on the left-hand side of the road. And so it's not wrong, but I had someone in my clinic who'd never been out of the country, didn't know they drive on the left-hand side of the road. So all this, I see these newcomers to the block doing studies, it's really hard to do it, and all that. It takes a little teaching, a little understanding of where the patient is to meet them, to know how to properly implement this. And we do an hour of teaching generally after a 1 hour intake, so I develop rapport with people, and 1 hour teaching. And then I see people every 2 to 4 weeks to reiterate and to reinforce what they're doing. People will stray, they won't remember this, and I say, that list of foods, have you stuck to it? Well, do you need another list of the foods? Well, here's another list of the foods. That's not brash, that's called teaching. It's a busy world, busy life. So what do people choose? People choose what they want off the list. I don't ever make people eat bacon, although a lot of them like it. Or you could have sugar-free yogurt with little berries at the bottom. It's a measured amount. There's no, pun intended, forbidden fruit. It's just you can't have much. Or if you have it and it stimulates your hunger for the fruit so that you eat the whole thing, I sabotaged you. So I'll make it simple and just avoid it at first, okay? So chicken Caesar salad or fast food burger. I had a guy come in, young guy, the exercise he does is video games on his phone or on his Xbox. And he eats two double cheeseburgers at McDonald's for lunch, no bun. He lost 40 pounds in 2 months. Fast food is not evil, it's all about the carbs. But if you ask me what is the healthiest diet on earth, don't eat that stuff. Well, so at what point are you going to compromise and say, well, it's really just the carbs? That's what I came to, trying to teach people from all walks of life, all different metabolism. Keep the carbs really low and just deal with those parameters. You get salmon with cream sauce, or the classic thing is the doctor to say what they like, so you must like it. Like, so a patient came back to me and said, the cardiologist told me to have more quinoa. And he said, what's a quinoa? Yeah, it's like, so doctors want to have success. They really do. They're just not taught the right thing to do. And the doctors that say, just exercise more, that's how I get the best credibility with my patients. I say, exercise doesn't help you lose weight. And they're like, well, but I've been exercising more and I'm not losing weight. I know, exercise doesn't make you lose weight. And then they realize that I'm speaking the language that they've lived, okay? So it's different than what we were taught. So individuals choose foods from the list that they like. So while taking to my clinic, just taking out some people with diabetes, the good and the bad, add up all the insulin, doesn't matter if it's long-acting or short-acting. Insulin in a person without diabetes, usually about 20 units per day being secreted by your pancreas. So this person's on 100 units a day. The blood sugars here ranging from 120 to 140. We want everyone to be under 100 on the blood glucose. That's normal, really. The weight here is 415 pounds. I teach and I say, are you going to follow it? Yes. Is this going to be different than what you were eating before? Oh, yes. A lot less carbs. I've been having bread, I've been having all these things. 50% reduction of insulin on the first day. Cut all the pills off. They're really weak. You got to cut the insulin down on the first day or they will go low on the blood sugar and blame the diet for it. So this is potent. It's just food, it's just a diet, you betcha. It's really potent. Or should we say you're taking away the effect of the carbohydrates. So basically over the period of 6 weeks here, this person came off 100 units of insulin per day with a 5-pound weight loss. The blood sugars are as good as before. This is not lightning striking once. This is reproducible and reliable. Add up all the insulin, 80 units a day, off in 1 week. Blood sugars 100 to 120, 100 to 140, 92. All right, we're getting some under 100. Woohoo! That's what normal. And this person lost about 28 pounds over that time, but that BMI is probably still, 40, 45. Another patient, one patient per slide, on insulin and a couple other pills, cut it in half in the first day, off in 2 weeks, 60 units of insulin. There's the weight and all that. 100 units of insulin, off in a couple weeks. It's like, all right, call me if you have a problem. This is really impressive, okay? Weight loss, okay. If I was up here with a weight loss surgeon, they do as good, and they do maybe even better. They cut off all of the medicines right away, but I'm not cutting them, okay? This is just food. So 3 weeks, off all of the insulin, blood sugars as good or, well, Dr. Westman, the blood sugar is not normal. Yeah, you didn't have normal either. It's just amazing. I heard from another doctor I'm talking to who uses this all the time. The weight was down, the A1C was down, there's the measure of long-term control, and the other endocrinologist told this difficult patient, I don't know what that means. Other doctors just don't understand. I don't know. This is all better. So keep going. Let's see, 160 units on insulin for 10 years. How long someone's been on insulin doesn't seem to matter. Often 1 week, 160 units. Blood sugar is better than before, now on no insulin. And oh, by the way, they can lose weight now because the insulin made them hungry and they were gaining weight along the way. Wow. So 160 units on insulin for 25 years, blood sugar is better than before, off all of insulin in just a couple months. A1C here, almost, well, this is acceptable to your endocrinologist. Of course, the A1C was 10 on all the medications. So what happens with insulin resistance, it is a continuum. What Jeff Volek was talking about, the early insulin resistance, and now diabetes is just the late stage of that. I think what's happening is there's a component of insulin used to treat the food, the carbohydrate, and then there's a component of the insulin that's being used to treat the insulin, underlying insulin resistance. So the diabetes is from the belly fat insulin resistance and the food. So you're going to get an improvement immediately by reducing carbohydrates, and then it may take longer to get the final curing or putting in remission of diabetes until you fix the underlying abdominal obesity. 500, so the current medical model is just give industrial strengths of insulin. Let's make insulin so strong that we have 500 units now in a very small amount. And soon there'll be 1,000 and all this. It's just, remember the basic pathophysiology is insulin's already high. We want to lower the insulin level. And in the defense of the doctors who use the medications first, they just haven't seen this before. Or they get in this rut of, well, none of my patients will want to do it. None of my patients can reduce carbohydrates. Well, then send them to me, okay? Give them a choice. And that's pretty amazing. So is insulin pumps, is that okay? Sure, it's fine. Let's see, there it is. Just reduce the basal and the boluses. So even if you have insulin dripping in constantly by a pump, you can overcome the pressure in the body to make and store fat by cutting the carbs down. This is impressive. And oh, by the way, pretty much none of these patients are exercising. My philosophy is all I want is control of the diet. So my program is just myself and a nurse's aide. It doesn't have to take a whole lot of people. All it takes is control of the food. And that's pretty impressive. Let's see. So over time, that was, the insulin pump. I didn't show a lot of A1Cs here because, I don't take them all the time. This is not a research study, but the daily blood sugars will be reflected basically in the A1C. And those people that I just pulled off here, this person had an A1C on the right side of over 7 and then now under 6 off the medications and had been over 7 for years, really. And another similar case. Now this is the the internist's dream. It's the internist, the obesity medicine doctor's dream because it treats diabetes, high blood pressure, heartburn. Interestingly, I heard the ketogenic diet for epilepsy in children as a common cause of heartburn. The most common thing in adults is heartburn is gone. And I was talking to Eric Kossoff about that, and I said, I think it's a medicine that they're on. And you're confusing the diet with a medication. I will have metformin side effects occur after the diet change that they didn't have side effects before they changed the diet. So you got to be a little bit of a detective, and whether it's the microbiome change or something, I don't know the reason, but you just have to, don't just blame the diet for things. I mean, you got to be a little more serious than that. So all the meds gone, these diseases are fully in remission. The blood sugar, I debated a local endocrinology professor whether someone could be cured of diabetes or have it just be diet controlled in remission. She said it was just diet controlled, and I said, well, but there's no evidence of diabetes. It's gone. If someone had an infection and you treated it, and you wouldn't say they have they have a strep strep pneumonia in remission, it's treated, right? So anyway, people are going to hold on. Doctors tell their patients they're going to have diabetes forever, and then they come in and they don't have diabetes. So anyway, I'm showing you a glimpse that most doctors do not know about, but remember, it's nothing new. This patient, A1C of 10.5, never been treated, first diagnosed, 64-year-old, BMI of 29.1. All of the guidelines that you would read today say this patient goes on insulin immediately. And A1 is out of control diabetes, got to go on insulin. Well, the doctor down the hall, who this is the patient of, kind of thought that Westman guy might be onto something. I've fixed a lot of his patients. And so he said, well, I'm just going to put him on that Westman diet. They call it that. It's just the no sugar, no starch diet. It's not my diet. It's been around a long time. But pretty impressive. He had a normal A1C within just a few months and lost some weight. But he now, a year, 2 years later, sustained it. Imagine now, you're not just eating this way because you like to have these foods, which are tasty. You're not eating this way just for any nebulous reason. You fixed your diabetes. And you're saying you're going to have trouble having someone stay on this? If you fix any of the diseases we talked about here today, over the last few days, curing epilepsy, curing cancer, curing Alzheimer's, all these, it's not hard to keep people on it when there's a tangible medical benefit from it, in my experience. So let me wrap up. Instructing people to limit carbs, and 20 grams is high from the blood sugar perspective of 5 grams in the whole bloodstream. It's low from the current societal point of view. Jeff Olick eloquently showed you how all of these metabolic syndrome parameters get better. Throw in the reduction in waist circumference and obesity. We didn't really show you that too much today. A low-carb diet is the preferred diet for metabolic syndrome and type 2 diabetes. The prevailing treatment of medications and high-carbohydrate diet was never compared to the low-carb, high-fat diet in clinical research. It never was shown superiority, and from my vantage point, it's going to lose if that study's ever done. I'd love to see someone do that kind of study send half the people to the typical endocrinologist, half the people here, follow them for a duration. It doesn't have to cost a lot of money. I'll help you do it. So what's up? What's new? You heard about some conferences coming up. There was I think a great important conference in Cape Town, South Africa last February called the Low Carb Summit. Brought people all from around the world, not only low carb, but the anti-sugar folks were there, and they're mad. Low Carb Vail is happening next month, Low Carb Cruise, May 1 through 8. Food Loose, I guess like Footloose in Iceland. I just got word of that in May in Reykjavik. I'm involved now with 2 companies that are trying to give more bandwidth to learning about this, adaptyourlife.com, and trying to create clinics around the country. These are all very new, and I get no money from them, but just want to make you aware of them. Thank you very much.
You made a comment at one point that you didn't think that insulin was involved in control of blood sugar.
Well, no, it's involved, but was it really designed for that purpose? If you look at cold water fish, PubMed, cold water fish, glucagon, and glycemic control, these fish eat other fish. So they're basically not eating carbohydrates. Fish really don't have much carbohydrate in them. Their blood sugars are totally glucagon dependent, and they're stable like this. The human physiology is designed the same way. Glucagon is a driver of glucose production and the blood sugar when you're not eating carbohydrates. So it's conceivable that often, it was explained to me also by Ron Rosedale, who's another thinker that I've learned from, that airplanes don't have any, with gravity, don't have any fail-safe mechanism to not go up too high, right? Because you don't have to deal with an airplane going too high. But you have all of these mechanisms to not go too low, right? Because then you crash. So like an airplane, the blood sugar has all of these mechanisms to keep it from going too low. You have the glucagon, you have adrenaline, you have cortisol chronically. Why would you ever have a need for a mechanism to keep the blood sugar from going high?
Well, wouldn't you say that your presence of insulin suggests that there was a need for it? I mean, that
No, look up physiology textbook off the shelf. The primary role of insulin is to help amino acids into the cells, and then to store fat when there's plenty around. I don't know. That's a conjecture. But I'm glad you asked about that. Yeah.
You could say a corollary to the fact that we need adrenaline, but we don't need adrenaline all the time. We need a sympathetic nervous system, but we don't need adrenaline all the time. We need it sometimes. Same way with insulin. If you're right, it would be a similar corollary.
That's right. Yeah. Great idea.
But I did have a question. There are indigenous cultures around the world where beans and rice are the staple. Now, granted, there's corn. And granted, there's probably lard that they use to cook a lot of their foods. But you wouldn't see the type of American diseases in those populations until they come to America and start eating the standard American diet. So it seems that there is some role in cultures around the world for carbohydrates, legumes, and whole grains in some proportion. Again, probably because of the lard didn't hurt them, and they didn't get those diseases. So I'm just wondering if you could comment. Because I didn't see legumes up there at all.
This is you could have a day of lectures on this. I'm not an expert. What I gleaned from what the experts tell me is summarized in a movie called Fathead the Movie. There's a clip you can even get from the website. I use this with my patients all the time. If you could put all of human history into 1 year, we haven't eaten grains, rice, since the last day. All of human history is 1 year. So you're looking back through history thinking 10,000 years is a long time. Beans and rice hasn't been around more than 10,000 years. Sorry, I mean, it was a construct today used to, again, people tell me, to help feed a world that has way too many people, which does not really mean it's the most optimal way to feed people. So if you could put all of human history into 1 year, we only had grains for 1 day, and then we only had sugar and vegetable oil for 2 hours. And then why did all the world's experts tell us to eat foods that we didn't eat for 99.9% of human history as the healthiest diet? That's the USDA food pyramid. Tom Naughton put together a fabulous movie, Fathead the Movie, that got me through the emotional, how could this happen, with just in-your-face kinds of things like that. So this could also be called the hunter-gatherer, the paleo, the other, but no, I don't think beans and rice were around a long time. One of the conferences that, or one of the lectures from the conference in Cape Town that really was eye-opening for me was by Mike Eads, who's now, he's got a protein power blog and has become sort of an amateur paleontologist. There you go. He gave a lecture on the mummies, their health out of Egypt. They had atherosclerosis and diabetes. And cancer. And then so you look on the wall of what they were doing. Bread, grains. It's not a modern illness. And that changed my view. I used to say diabetes is a modern illness. And all. No. Just think this through a little more. There are a lot of kind of sound bites that you'll hear like that. And you know, the rice diet exists in Durham, North Carolina. It's just you can't have much rice. It's an 800 calorie per day program. But what people see is the rice. Oh, rice must be good, must be good. But you're not getting much of it, and everyone's burning their own body fat so much. It's really a 60% fat diet from the cellular point of view. Anyway, so yes, sir.
A mundane question, and a related question came up next door on cancer. Any place for alcohol beverages?
I think research should be done. And you know, I have a lot of people that want to volunteer for that study in my patient. So I have
Just in terms of the carbohydrate potential, you just have to limit that in the same way?
so again, I don't know, the way I teach it is, while there are no carbohydrates in alcohol, they still count in terms of fat burning. And so remember, I'm just really creating fat burning machines. And you know, what's the kind of weight you want to lose, sir? Fat weight. Well, then you want to burn it. You want to be a fat burning machine. Alcohol can interfere with the fat burning going on. And I don't know, and then clinically that's true. I'll have people having a glass or two of wine or beverage a day and it'll work fine, others that don't. I don't know how that would fit in therapeutically with cancer until other studies were done. But it can interfere with ketosis. So if you're trying to enhance the ketone levels, you just want to measure it and see how your body responds. And there's a lot of individual variation. When I heard the pediatric group today, I was a little disappointed that they're not measuring biologically each child, because in adults, unless you're really strict like this in adults, there's a lot of variation. And I can very well imagine that, as Jeff pointed out, that a third of Americans can probably eat all those foods and be fine. But that means 2/3 can't. And so the more we can measure something in an individual biologically, like the blood ketone measurement and blood glucose measurement, can take you a long ways. A lot of my patients do that, but I don't insist upon it. I think there's
fiber, then you cancel out 2 grams of carbs, you have bread or all that low carb stuff.
Well, the fiber story is kind of interesting. I mean, there's the whole notion that you have to have it to prevent cancers and all that. Well, I think that was pretty much debunked in large randomized trials. The idea of fiber impacting the blood sugar is real. And so the historical use of low-carb diets, since William Banting described his experience in 1863, basically, and the doctors who used low-carb diets in the 1900s used total grams of carbohydrates, not net grams where you subtract out the fiber. Having met with fiber experts around the US, they've told me that some people will absorb some of the fiber. So it's not, some of it's even called absorbable fiber, but even the non-absorbable fiber can have an impact on the metabolism. So if someone comes to me from, Timbuktu and they want it to work first time, I'm not going to take a chance that someone can absorb fiber. So I use the total gram method, which includes fiber in that calculation. Now, these rogue doctors, 5 years ago, I was one of them, wrote the new Atkins for a new you, and it teaches net grams and subtracting that out, and that can work for people. But in my experience, if someone has diabetes, metabolic syndrome, has a lot of weight to lose, the total gram method works better in my clinical experience. That's a great study that could be done rather simply too. But I assume people absorb some of the fiber and include it in the calculation.
Especially in population studies, people are often categorized as diabetics, pre-diabetics, or healthy based on HbA1c, percent of glycated hemoglobin. In a lot of analyses that are done on aging adults, it seems like pre-diabetic individuals they have metabolic profiles and inflammatory profiles that look a lot more diabetic than healthy people. So often if I'm comparing, if I just want to cut them out in two groups, healthy and healthy, how do you place the pre-diabetic together with the diabetic? I mean, that's a lot more consistent that way. So I don't like the clinical cutoffs that population study research should have the some insight on what would be an ideal HbA1c level to use as a cutoff as being healthy.
Yeah, that gets into the bigger issue of what is normal and what is optimal, and what normal is often defined as what is seen most frequently, and is not necessarily optimal. I would say the lowest you can. In fact, it's probably off the scale low, being the healthiest, although those kinds of studies are very difficult to do. I mean, you need to follow a cohort of people for their lifetime. Yes.
Well, just to speak to your question, the problem with the HbA1c has been shown in studies that, you know, somebody with blood sugar of 214, they might have an HbA1c range of a span of like 6 or 7 points. So it's a not a specific measure of average blood glucose over that 3-month period. It does range and depends on the individual. So sometimes relying on that's not going to get you where you want to be.
I just want to chime in on that because when you constantly red blood cells, say so constantly the life, so it's 120 days. So if somebody changed their lifestyle, you're going to see it dropping down. Not absolutely, you have to have what's called constellated pass through and go through senescence. And so
that's something that you consider in my analysis. So there are a lot of compounds. One of them, if you had a big sugary meal the night before, that's going to gradually affect your HbA1c.
You're not letting your patients do that, are you? Not after this conference.
But if it's like age, equals the turnover of hemoglobin, that also affects the exposure of sugar. So there are a lot of compounds used in this research. But it is the one marker that researchers use in population studies to categorize, diabetics, non-diabetics. And the way that it's divided, I think, creates some confound in what you find or
That's a good point. Do you have a question?
Yeah, quick question, Eric. How many visits, the intensity of the visits with either yourself or clinic staff to get them to the point that they're good to go and they might need to see you every 6 months, but they get it?
That's a great question. It really depends on the individual. What I say at the beginning is I want to teach you so well you don't need me anymore. And most people stay in forever. So, although at a year, I don't have formal statistics, but I'll get a resident or student who's gung-ho to take the consecutive sample of 100 people and follow them for a year. I have about a 50% retention rate. And if you look at those who are still in and then fall out, are not in, and you go into the computer and find their data, those who stay in have better A1Cs and better weights over time. It's conceivable there are people who get trained really well and then they just don't come back and they do really well, but I don't have that long-term follow-up. If someone declares themselves and they can't do it on their own and they need help from someone like me, what I learned from the obesity medicine field is that they're going to probably need you forever. It's a chronic disease, it's a recurring, around holidays, people fall back into carbs from my vantage point, or calories from the low-fat vantage point, and resurface and around Valentine's Day and say what happened. People can lose weight the whole year and then regain all of that weight just in a couple months. So until someone has done it long enough, I basically let them declare to me how long they want to stay in. So my program is very flexible, and I'll say, when do you want to come back? And then, do you want to come back? And most people will just stay in as long as they can.
The residents and students that are rotating, how many of them that you see actually implement this, or do they leave and this was a curiosity? I know you probably don't have data, but do you, a year later, hear from them?
Well, through the years, one went into obesity medicine. Yay, went to a different program, but and they actually co-opted a geriatrics fellowship to train the obesity. So I have enough contacts around the country to help facilitate that. But she went to St. Louis. The students or residents in their own clinics try, and they'll hand out the list, the magic list of foods and all that, and but they don't really support well. So you'll get a percentage who will just do it of patients, of individuals. People read a book and they have good results, and then there are those who you hand out and you have to reinforce over and over. So I guess I evaded your question.
Students rotate through, but that's the next generation coming up.
Eric, when you showed me how to do this, I think it was 2009 through IMS, we didn't have all these supplements. I'm just looking at some of the slides are the same, but some things haven't changed. But now we've got a whole room full of all kinds of supplements out there. How do you plan on using those, or do you, and how would you recommend that we start to incorporate those in patients? I mean, most patients do really well, but some don't. Maybe there is a...
So I have two rules. I try to make things simple. If it's not on that page, you can't have it. And I'll say that for a half hour. If it's not on this page, I call it page 4, whatever page it is. And so if you say, can I have the Atkins bar? I'll say, is Atkins bar on page 4? No. Can I have, whatever product? No. But then I'll introduce about halfway through, well, there's another rule, and that is if you can stay under 20 total grams of carbs, it might be okay for the day, right? Even if it's off of page 4. So that's getting into the idea that someone wants something quick. They understanding that the physiology in general, if you keep it under 20, you're not going to be interfering with the fat metabolism, fat burning very much. So to the extent that you can introduce, in our area, there are these different shakes that pre-mixed that have 2 to 5 grams. You might have protein powders, things like that. But my general philosophy is I want you to eat real food as much as possible, so that I will I'll say I don't want you to have that as your only source of nutrition, but every now and then if you have it, it might work. And then if they come back and they say, well, I'm having this and it's not working, but is it on page 4? Is it on the allowed food list? So the rule number 1 is stay to the real foods. But if you want to introduce these other, snack food ideas or intermittent meal replacements, in my experience, it might work. But again, it's an individual thing.
I don't feel so old-fashioned now, thank you. But I've had some patients who go to these health coaches who want them to lose weight, and they come back with all kinds of exogenous ketones. And I'm saying, well, I really want you to burn your own fat. But they're being told that, well, maybe this turns up the thermostat or something.
I've had, clinically, if you're drinking your calories, whether they're sugar calories or fat calories, it's a calorie that you're not going to burn on your body, off your body fat. Now, if it does keep the satiety down so that you don't eat later, but in my experience, I don't think people meter the amount of calories from drinking them very well. You can drink a whole lot of butter, oils, things like that. And I've seen clinically have that make people not lose weight, because it is a matter of the calories at the end of the day. So, you never heard me say that we count calories, because we don't. The hunger goes down so much that people just eat less. But you can overcome that. The gentleman, he saw my list that said you can have as much bacon as you want. He went out and had 3 pounds of bacon a day, and the thrill wears off over time. But there are people who will consciously try to just, well, the doctor said no, it won't work. So there's nothing mysterious about this. The weight loss and the diabetes is measurable. It's from the carbs in the food, from the calories in the entire day. But I just wanted to, the other advantage of doing this is you really don't have to have exercise. And if someone's 500 pounds and they can't exercise, well, my knees hurt. Well, I don't need it. Well, but my knees hurt so much. My doctor said I needed exercise to lose weight. Well, I don't need it. All I need is control of the food. So I hope you've had good experience clinically.
What my take off of this is what's worked for 100 years still works. And back then they had whole food, and it works.
Okay. Yes.
To go back to the earlier question about what proportion of patients stay on the program long term, do you have data on rate of relapse, if any, of diabetes long term? So you show those beautiful pictures of diabetes going into remission. Do you have data on the rates of relapse?
Yeah, sure. Of course, it's totally dependent on whether they're following the program or not. Totally dependent on whether they're following the program. So the diet itself doesn't stop. So Manny Noakes said this years ago, you're not just studying the diet, you're studying the adherence to the diet. It's all in one fell swoop. So it's not like, so if someone starts eating carbohydrates again, the diabetes comes back, it's not that the diet stopped working, it's just they're not doing it anymore, right? So it's all in the same fell swoop.
In terms of impact on society, adherence is part of the treatment.
Exactly.
So what feel do you have for the rate of relapse?
Again, in my clinic, I have a whole range. I have an indigent care medical clinic in the university, and I have people who fly across the country to see me. The motivation and education and adherence is dependent on lots of things. It's not always predictable. Sometimes people are overeducated, and then they start worrying about the blood cholesterol of this and that, and then they start eating carbs and their diabetes comes back. So it's complicated, and I would say that out of probably 50% will sustain the carb restriction even under the best thing I can do now. But when I go back to the 1970s, for example, when exercise started, can you imagine being here and everyone should exercise, and you'd be here smoking. There ain't no way anyone's going to exercise. And I look around, no one's exercising. I mean, you go to France, go to Europe, who's jogging, okay? I mean, so things can change quickly. To get the cart before the horse, is, in my mind, to say, well, population-wide, it won't work, so we won't do it. That would be like saying exercise can't work. No, I think it's education, and right now, to focus on the people who are motivated and want to do it would be the biggest bang for your buck. The people who really like me are the ones who were spending $1,000 on their medicines per month. They're in the donut hole in our insurance system, so that they're paying all that other money. They save that. So there can actually be immediate financial benefits. But your point's well taken, and I haven't shown the long-term outcome data to say that it is effective. Well, the best study for low carb in general is that workplace diet trial that David Ludwig talked about, where the carotid intimal thickness got better regardless of what diet, including a low carb one, over a 2-year period. But most people, even cardiologists, would acknowledge that if you fix diabetes, that's more important than prattling about a blood cholesterol. I mean, it's a huge risk for cardiovascular.
So in my practice, what I'm finding is it's just as much the behavioral changes in people. It's like if you can get the family or the community around them making these changes, that's what makes it sustainable. Because if you're the only person in the room changing this lifestyle and everybody else around you not, I see that as the biggest indicator of how long it can last for people.
Well, unless you're an individual who wants to be the leader. You're the, passive aggressive, yeah.
Which we find is not as often, at least that's what I'm finding. But if I can get 1 or 2 or 3 people around them participating at some level, I see that change is much longer, because there's a huge behavioral, just from a community standpoint, that makes it sustainable for people. So,
do you ever get people who are very staunch vegetarians or vegans? And what do you do? How do you manage with their care?
You can do vegetarian low carb pretty well if you're having eggs and other sources of protein that are low in carbs. It's a little harder to do vegan, very low carb, but the new Atkins book, published in 2010, has a section on doing low carb vegetarian. Even at the Atkins company, they have resources, and if you Google low carb vegetarian, I'm sure umpteen things would come up. And you can Google low carb anything, and a lot of ideas come up. The only thing in my clinic population is I make people watch the total carbs, not net carbs, when they're out and surfing for information. But yeah, I don't think the body cares about where your amino acids come from.